Well, thanks, Anita, and thank you all for sticking through this to the bitter end. I'm going to give you a very brief glimpse into the future, and as I alluded to earlier, I'm not that prophetic, but the molecules I'm going to talk about are really the near future. These molecules are in phase 3, and they all have a very, very high probability that they will be approved by regulatory authorities. So you're going to be using them. These are my disclaimers. And so looking at the wave of therapies, well, why do we need them? I think all the cases presented today show why we need them. Our current therapies are plagued by incomplete responses, and we need very high remission rates, and we don't have them. So I'll talk about small molecules briefly, monoclonals, and some future directions. So small molecules, small is the new big, and we've started with the Jak Kinase Inhibitors. And I thought we had a good discussion about TOFA and its characteristics, its advantages and its limitations. The limitations being off-target side effects. The advantages being it's a very effective agent because of its biology. Well, there are multiple new Jak inhibitors on the horizon in phase 2 and phase 3, both in UC and CD. And in Jak inhibition biology, and I've spared you that, but suffice it to say that the docking receptors are promiscuous and they mix and match. And one of the concepts is that TOFA being a pan-Jak inhibitor, there's Jak1, Jak2, Jak3, and just to confuse the hell out of you, there's TYK2, which is essentially Jak4. And TOFA is broad, it inhibits them all, and the notion being that perhaps you could get better off-target side effect profile if you concentrated on Jak1. So there's several molecules that have Jak selectivity. And in most of the data supporting that concept are based on in vitro, essentially, assays that are looking at the affinity of the various JAKs for the various molecules. And so in terms of studies that have been done in people to verify the selectivity, we really don't have those. So it's going to be empiric data. So I'll just show you some of the efficacy data empirically. This is filgotinib in Crohn's disease. Tofacitinib was evaluated in the same doses it was trialed in UC in Crohn's disease. The study design was unfortunate in that there was a very high placebo rate, which really hasn't plagued modern studies. So that was a problem with the study, and I really think if we went back with TOFA, we'd see similar results to this too. But nevertheless, a very good safety, a very good efficacy profile in this short-term induction study in Crohn's disease. Similarly, upadacitinib has been evaluated in both UC and CD, and I'm just showing some of the data here from this UC study, and what we see is, again, endoscopic and clinical remission rates that look quite favorably. And this molecule is going into phase 3. So multiple JAKs, and again, I'll speculate that the JAK selectivity will not solve the problem as far as broad-spectrum immune suppression and increased risk of infections. Now, one exception might be the TYK2 inhibitors, in that TYK2 does not interfere with natural killer cell functionality or interferon gamma production, which are key antiviral effects. So you may not see the viral effect with TYK2s, but they're in phase 2. Another approach to improving the therapeutic index of the JAKs would be to locally deliver a JAK. And this is a press release from a molecule that is now in phase 2. This was an early phase proof of concept study of a locally delivered JAK, the company being Theravance, a numbered compound, and they're co-developing this with Janssen. So I think this might be a very nice oral drug, potentially, if it ultimately proves to be effective in a phase 2 study. Now, sure things. Okay, so the S1 P1 Antagonists are going to be the next class of drug in ulcerative colitis. And this molecule is ozanimod that I'll talk about. There's also trazimod. And they are second-generation S1P1 agonists. The sphingosine 1-phosphate receptor is a very important molecule for lymphocyte homing. And you can think of this mechanism as the opposite of the integrins, which you're used to thinking about. So if lymphocytes require specific mechanisms to get into tissue, they must require specific mechanisms to get out of tissue. And the way that works is that there is a gradient of sphingosine 1-phosphate receptors on the cell membranes of the endothelial cells in the lymphatics. And the gradient goes from the center of the lymphocyte at low concentration to high concentration on the way out. So the lymphocytes bump into these, they follow them along and get out of the lymphocyte, get out of the lymph node and return to the systemic circulation. So what these molecules do is actually, they're agonists, they interact with the receptor, they internalize the receptor, so the lymphocyte is now blind and can't find the gradient and is stuck in the lymphocyte. So these folks, when the clinical trials are done, we had to be blind for the lymphocyte counts, just like with the natalizumab studies, because if you give natalizumab to some, their lymphocyte counts go up 40% because you're blocking alpha-4 beta-1 VCAM interactions. You're blocking trafficking right across all the vascular beds. Well, this does the same thing in reverse. So you actually drop your lymphocyte counts about 40%. So the first efficacy signal was this study in the New England Journal of Medicine, and you can see a clear dose response, 1 milligram versus 0.5, and increasing efficacy against placebo out to week 32. This compound is now in phase 3. The study is fully completed, or fully recruited, and will be completed within the next 6 months. And I think it's a very high likelihood that this will be successful. There's another drug called etrasimod, which had a very strong positive phase 2 study, which effectively recapitulated these results. Now, I'm not going to talk about the side effect profile. We need a full session on that for these drugs. They are small molecules, they have off-target side effects, but in my opinion, they're probably manageable, and they'll ultimately be an oral drug that may fit in before some of the drugs that we've talked about today in UC and potentially Crohn's disease. Now, on to monoclonals, new anti-integrins. I talked about anti-beta-7 this morning and its mechanism of action, blocking both alpha-4 beta-7 mediated trafficking and alpha-E beta-7 trafficking. Phase 2 results were published back in a few years ago in Gut, and positive signal, and the molecule is now in this enormous program, which we'll have the results for very soon. So you may have a new anti-integrin therapy. And then probably one of the more exciting topics targeting 12 and 23. And for those of you who are closet dermatologists, no one wants to admit that, so you'll see the evolution that's occurred in psoriasis therapy, and this really is an amazing story. And if anyone is planning a career in dermatology, I advise in psoriasis therapy, you need a new vocation, because this story is just about over. Over the course of 10 years, we've seen psoriasis efficacy outcomes change from, you'd be lucky to get a PASI 70 score of 50% with the first generation therapies. Now we're seeing in multiple direct comparisons shown here in the New England Journal, TNF blocker versus ustekinumab, and then anti-IL-17 or anti-IL-23 against ustekinumab, clear-cut superiority, such that we're now talking no longer PASI 70. We're talking about complete remission rates approaching 80%. So this is a really dramatic story. And, well, what about Crohn's disease? We talked about ustekinumab all day, 1223, that works in both UC and CD. What about blocking with P19-directed therapies IL-23 itself, as per the success story in psoriasis? And this was a study we did back a few years ago with risankizumab. It's hard to avoid risankizumab these days, that Skyrizi commercial with the reggae music and that woman dancing all over the place. These are the data in Crohn's disease of the first study of risankizumab, and you see a very nice dose response here for both clinical remission endpoints and endoscopic remission endpoints at week 2. This is in phase 3, and I think that this is likely to be successful. Now, one caveat I'd say is that it's not going to be as successful as it is in psoriasis. So we still need better therapy, and I already tipped my hand as far as my prophecy of the future as far as therapeutics, that it's not going to be single drugs, it'll be multiple drugs. So I'll summarize the next wave of therapies by saying that TOFA's here, we've got multiple JAKs, and it bears to be seen whether JAK selectivity will improve the therapeutic index of these newer compounds. The S1P1s will be the new drugs as far as oral agents, and our new monoclonals are on the way, and the 23s in Crohn's disease, I think, are going to be really good drugs. So the landscape's going to change. You've got 3 new classes of drugs, and it's all good news, but it comes back to that fundamental therapy. Do we have a game-changing therapy that will really be revolutionary here as single agents? I don't think so. So thank you.